Okay, Isa. So, hi everyone. Welcome back from the holidays. I hope everyone had a peaceful time with their families and time for gathering and lots of cheer for everyone. Um, to start back on our ground rounds, we have a nice uh, lineup starting with Isa. Who we're all happy that she is got great news in her life. So we're just happy for you and very the best for you. You want to take over and start, Isa?
Okay, so we're starting our ground rounds. I'm excited to be the first one to this year. So I have no financial disclosures and I'm going straight forward as Genutsi likes. So we have a young female patient, Hispanic, presenting with photopsias, paracentral scotomas, and metamorphopsias of 2 days. And anterior segment was remarkably okay. Pressure was okay. And I don't know why either. Okay. And you can see we have a visual acuity of 20/20 in the right eye and 20/20 -1 in the left eye. And as you can see, the fundus photograph here, you might have some differential diagnosis, or you might even be thinking in the diagnosis already. So I'm just going to describe that. We can see the nerve, which is very defined. The excavation is pretty small. You can tell like the vasculature is a little bit like reverse. But most importantly, in the left eye, you can see this lesion, whitish cream, that kind of like confluence. And so this is like our most important finding. And right now we're gonna like mingle things a little bit. So I want you to participate and think all of the diagnosis we could be thinking, but don't go straight forward to the diagnosis that is much more possible, but think more in like all of the possibilities that we need to rule out here. So I don't know who wants to start to participate. Maybe Pamela.
Centros choroidal, una serosa.
Okay, that's a possibility. Yes, I'm gonna be writing them. Someone else?
I'm wondering about like a lymphoma, or although it's unilateral, I'm wondering about some type of blood dyscrasia lymphoma.
Yes, that's another one. That's perfect, actually. Another one?
Maybe this is too obvious, but one of the white dot syndromes, like Mudes.
That's great. Thank you. That's important to rule out. Yes.
I'm thinking serpiginous or something like that.
Very important. Yes, thank you. I don't know if like someone wants to share another differential. Maybe Claudia, Mariana. I'm gonna put the image again because there's people like coming into the meeting. So we're just trying to think in all of the differential diagnoses that we should be thinking in a patient, in a young patient, Hispanic, female, presenting with photopsias, paracentral scotomas, metamorphopsias, and this fundus. No alteration in anterior segment. So I don't know if like we have one or two more diagnoses. Something very common in Guatemala, infectious, for example.
Toxoplasmosis.
That's great. So this was just a little exercise to come back from that long vacations that we had. Okay, so we're gonna start with the differential. Someone mentioned multiple evanescence white syndrome, but that's definitely something that we should be thinking at when we see these whitish cream lesions. But there is a like a spectrum, a complete spectrum. So that like in Ryan, they actually see it as a syndromes or as a group, and they all include Bishop chorioretinopathy, acute posterior multifocal placoid pigment epitheliopathy, idiopathic serpiginous. Someone mentioned that one, relentless placoid, chorioretinitis, persistent placoid maculopathy, punctate inner choroidopathy, and acute sonua occult outer retinopathy. So this is something we need to like rule out in characteristics and clinical sign, etiology, and also we should be thinking at the age of the patient. And then we should definitely think in masquerade syndrome, like Andy mentioned. We should be ruling out intraocular lymphoma, syphilis, of course, because that's syphilis. I'm surprised nobody mentioned syphilis because that's, I mean, I remember every test in retina, I had that in mind. You can never go wrong because always thinking in syphilis is the right answer. And then granulomatous disease like sarcoidosis, tuberculosis, sympathetic ophthalmia, and of course, infectious etiology in our setting. So we should be thinking definitely toxoplasmosis with this kind of white lesions, pneumocystis choroidopathies, histoplasmosis. Why not Beset? I never seen a Beset in Guatemala, but why not? And HIV. So going back to our patient, this is, of course, we're gonna send images, and maybe like Ana Paula can like tell us what other images would you suggest to send in this patient?
Geography.
That's perfect. Maybe another one that we have in the clinic.
Clinic studies such as HIV, syphilis, toxoplasmosis, infection studies, infection clinical studies.
Oh, that's great because Ana Paula like just coming in and she's already thinking in all of these possibilities that we can diagnose. So thank you, Ana Paula. You're ready for the year. And but we should definitely send an OCT, don't forget. So FA, OCT, and of course, if we will be like in a more robust setup and we have like more availability, we should be sending a lot of all other studies that we're gonna see in the next slides. So this is our patient. This is actually a patient I started seeing as a fellow. And as Jesse would like to teach all the time is that we need to have a beginning and an ending. And since I'm like, now I'm an old woman married and everything, I finally have like long patience, like in long follow-up patients. So that's very cool. And so red-free image that you just saw, I'm just coming back, just highlight how we can see there's fluid around our macula or a fovea, or it appears to. Maybe there's not. We're gonna see when we have an OCT, and then it highlights the lesions. They kind of like are dots and confluent, and we don't see any other lesions in the right eye, but just like small dots that kind of looks like maybe some deposits, but chronic deposit, nothing important that calls our attention. So the FA, this is the right eye, and we see an FA of a 20/22, so it's a 45 degrees, and we can see that's unremarkable. And then in the left eye, I mean, this is beautiful because this is by the book. So if someone has like the diagnosis already, please don't say it. And so we're having a hypofluorescence sign in the first phases of the FA. And then as you see in late phases, it's hyperfluorescence. So this is as Gus described it. And now we have an OCT, and this is the right eye. We can see everything looks normal within normal limits. And then the left eye, we can see the outer layers, the outer retinal layers are affected, and you can see these hyper-reflective areas in the outer nuclear layer, and you cannot distinguish between the ellipsoid zone, the ERP, and so all the external layers are kind of affected. And I read another description of a very interesting description that I'm gonna mention, so I don't want to ruin the surprise, but some authors will mention that's like, it looks like it's like there's kind of a fusion of them. So that's another way of saying it. So of course, by now, Ana Paula wants all the past medical history, because I mean, she's already thinking in all of these possibilities. And of course, we need to do a review of systems. So this patient had a history of headache in the last week and no history of fever or flu symptoms. And she had contacts with dogs and cats. In her past medical history, she had a history of migraine and allergic rhinitis. And in her past ocular history, she's a high myopic with -3 diopters in the right eye and 3 diopters also in the left eye with just 1 diopter astigmatism. And in her family history, her mom passed away like 3 months ago of cervical cancer. So very sad. She take no medications. And so we then did send the labs that Ana Paula said, and everything was okay. I mean, we couldn't tell. We even had a brain MRI because of the headache and the sign thinking in this white dot syndromes. So, and it was normal. And then, so we are really ruling out a lot of possibilities here. And we're left out with this placoid spectrum disease, which include acute posterior multifocal placoid pigment epitheliopathy, serpiginous choroidopathy, relentless placoid choroidopathy, and persistent placoid maculopathy. Of course, each has their features. So we're going to talk about that. And of course, I'm guilty as charged. I did treat urgently because it was very close to the phobia, and I was probably very young, and maybe I will do it again. I'll give it a little bit practice alone, but the patient started resolving the lesion. So in weeks, I mean, this is a picture only with the smartphone, 1 week, 3 weeks, and 8 weeks. We cannot see the widest lesions as we started seeing, and you can see how like some pigmentary changes are starting to present, and the symptoms are starting to resolve too. So patient, it's happier. 3 months follow up, and now we have a 20/20 in both eyes. Patients still feel a mild discomfort for reading in the left eye, and I mean, she's not having any metamorphopsias or the initial symptoms, but she does feel, she always refers like she feels funny that eye. Okay, so and we can see how we can start like looking at some changes in the pigmentary epithelium. So I'm gonna leave this, and we did some studies again, what we have available, of course, and this is the red-free, the FA that looks okay, and ODA. And now this is the left eye. Of course, you look at this and you're like, oh my God, what's happening? But actually, this is just window defects. So this is a resolution of the illness. And by now, we have a better OCT in the left eye. And as you can see, we don't have that lines, hyper reflective lines in the outer nuclear layer that we were presenting. And we're starting to see that the ellipsoid zones are more pronounced. And this is our perimetria. So I was telling Melanie, I don't know if she is already connected, that she might make some better assessment about this study, but I don't see her. But maybe we can ask Jorge, because they were reported like within normal limits, and I could just see that she had a lot of loss of fixations in the left eye. But maybe you can help us, Jorge, here.
Yeah, well, here at the bottom of the study, you can see how she wasn't doing very well during the test. You can also see down at the bottom of the standard deviation, down bottom right, you can see a few spots. They're not super significant, but they probably fit with the area that was damaged. I mean, this is obviously because I saw the pictures and I saw the eye, I can sort of imagine where the lesions could be, but that could certainly fit with that loss. We would have to do another visual field to see if that progresses anywhere, but and I also have to say, you know, this is her first field, and she could have, you know, just if we do another field and that clears up, then it was just a false positive. But I can certainly see a drop of like a little defect of decibels down in the on top and left on the nasal quadrant of the left eye. So yeah.
Nice, thank you. So we should repeat this to see how like the patient is right now, if that's like any continuous diminish of some scotomas. That's what I understood, right? Thank you, Jorge. And this is a 2-year follow-up of the patient. Now we have wider images, and the patient is 2010, which is funny because I just wanted to, like, I don't want to show up, but I'm just like reminding that in retina, we do have good vision sometimes. So, and you can see the left eye, we have this scarring of the lesions. They look very dry. But it caught my attention that I could see kind of a whitish lesion again here. And also in the superior temporal area, I saw another one. But I was like, okay, but she had no symptoms other than she was like feeling funny to breathe at the end of the day. That's what she said. And this is the FA. It was too new, probably because I think the technician didn't know that the patient didn't have to move the eye. So this is what I have. But it looks very nice, the right eye, and those lesions, they're not reflected there. There's no hyper or hypo reflection. So I mean fluorescence. So we're okay. And this is the left eye, which is a way better FA. And you can just see how we can highlight the window defects, but in the area that was what I was worried. You might think there's, but then I correlated with the photo, and that's not hyperfluorescence because it just continue over the time in all of the FA. So I was just happy to say that it was dry for the moment. Okay, so now since we have all our placoid syndrome, and we want to differentiate, so we should be, so this is just a little tip, differential, we call it tabla. I don't know how to say it in English, but it helps you think how you can differentiate all these syndromes. And of course, as we have seen over the time, I mean, the placoid, I mean, the epitheliopatia, I'm sorry because I'm switching to Spanish, but the acute, how do you say that in English again? Acute epitheliopatia placoide multifocal. I'm sorry.
You
I
can call it AMPI for short.
AMPI? Okay,
Yeah.
thank you. So I'm gonna call it AMPI. So it's a young patient, lesion heals over weeks. So and ours like was 3 weeks and it was very dry. And visual outcome is a good prognosis. Ocular involvement usually is more like posterior pole. And systemic involvement you can be having, and in the other two syndromes you shouldn't. And then the recurrent, it's like very, very rare. Usually it's uniphasic, it's called it. And then the treatment often it will just get better without it. And then of course the other syndromes, I mean, lesions heal after weeks or months, and then it usually kind of like have this recurrence. And also of course it's when you have relentless or when you have these placoids are like continually active, you should be thinking in immunosuppression. So it's like you should differentiate this, of course, with the FA, even though they have a lot of similitude, and also because of the lesion have a different presentation, as Sarpichinose will present kind of two presentation, of course, one that comes out of the nerve and has it and is very characteristic, you wouldn't miss it, and that's like one that's specific from the macula, and then the other one's like more scattered around, but and even goes to the equator. And now that we're having these ultra wide images, of her AMPI, it's presenting we're more like some peripheral lesions that are described in some authors, but like very characteristic that's in the posterior pole. So now we have that clue to help us, and also that the features in the I can see it now, acute posterior multifocal placoid pyramic epitheliopathy. That was Gas who did this to me, but okay, it's a beautiful name. And so in the FA, we have the hypo and then the hyperfluorescence. So I think that's beautiful described in this case. We don't have indocyanine, but you could in the United States have it. So probably you're more familiarized with this illness than we are, because this is the only patient I have seen with these syndromes or this possibilities of syndromes. And then of course we should be doing autofluorescence, which will present with initially hypo and then hyper again in the acute phase. But then of course after, when we have healed lesions, you will only have usually hyper in the areas that are damaged, but you will be having hypo because you have pigmentous area. So that's very interesting to see. But you can only miss when one is like active and one is dry, because they do look very different. And then of course the OCT, which you will see that disruption of the ellipsoid, the hyperreflective line in the outer, that looks very, very, very defined. And actually I brought you a new classification that came, I think it was 2012, I think. Yeah, but it's like more, it's like, I will say beautifully defined and very early taking these photos. You'll see it in a moment. And then of course, if you have an OCT with an enhanced dip, you can see there's correlated thickening. And of course, as Gas described long time ago, he even called it, he called it epitheliopathy because of the affection of the epithelium, but he always described it as a choroidopathy, which is amazing. His observations always will surprise us, because now with the OCTA, now we can really see and measure that the lesions are bigger in the acute phase in the area of the choroid and the choriocapillaris, and smaller in the area of the epithelium. So that's like just highlighting that the inflammation starts in the choroid. And so of course we have an MP as a diagnosis, and it was described by Gas as I've been mentioned, and it can be, he described it initially in 3 females, but you can have it equally in men and in females. Usually it presents in a younger population than the other syndromes, and it will go from 20 to 50. And other literature brings it down to like 40 years old. But there have been some descriptions of AMPI in patients like a variant in over 50s, but usually it's younger patients. And then of course, don't forget these creamy lesions, multiple kind of like flat but brown, and at the end, like they're like confluent, and the lesions that this usually tend like to resolve, creating or leaving back a pigmentary or hyperpigmentation, and also like a mottling. And usually they describe it as bilateral, but you can have it unilateral. And this is the classification in OCT that I was telling you that I think is brilliant. So the stage 1A, actually, this has like a dome shape, and this is I mean, like in the literature previous, we haven't described this because probably we never seen it that early. And then this author, I'm like describing it in a like hyperacute phase. So probably before the stage 1B, that is the one that my patient, we can see in the OCT, because there is when you can see like this hyper-reflective line in the outer nuclear layer. And what's like, I think really interesting is that this describe it like an engrosamiento. How do you say engrosamiento?
Thickening.
Thickening.
Yeah, a thickening of the outer layers, meaning the ellipsoid zone, of course the epithelium RPE, and then of course in the stage 2 we are seeing how this is like getting more normalized, but we still have this disruptions of the outer layers. And in the stage 3 we can see more like these lines are kind of like junction. Alexa, enciende la luz de sala. Alexa, enciende la luz de sala 2. I'm sorry. I'm so sorry about that. So, and then in the stage 4, you can see how everything normalizes, which is like a stage where it's always like that's completely recuperado, like a recovery. And we see how we can perfectly see the ellipsoid zones, which is our zone that tell us that the photoreceptors are working as before or perfectly. So I think we should be using more this classification, so to follow on the patients with an OCT, which of course I didn't do in my patients. So I'm so sorry about that ignorance. And so this is something that I also found that I love, because before OCTA, before everything, I mean, I think this was described like in 1999 or something by Spade, which we all know he's like a genius. But he said that he described infiltrates in the choroid with these pictures, which I'm just thinking, I mean, I've probably seen that, I missed it. And you can see that whitish lesion in a photograph, and then how the same area in the choroid, of course, that's choroid vasculature that you can see in this patient, and it's just resolved in 10 weeks. So that's also beautiful, and that supports that the inflammation, of course, comes in the choroids. So they've been describing retinal vasculitis, but this is like all of this are just in some reports, so it's not the rule. There have been described retinal vein occlusions, neovascularization, subyelloid hem, and disc edema. Also, the inflammation can be very variable, but it's not usual to find. So you can be finding vitreous anterior uveitis, granulomatous anterior uveitis. Really, you have to rule out all the infections. And it's very rare to find chorioextremal infiltrates, which calls my attention, but has been described. And now the vision improvement, it's very good, and it's usually very fast too. So you have good news for the patients usually, and because it's a good prognosis. But the bad news is this patient, if their vision is exquisite, I mean, we definitely will be feeling this kind of difference in reading, especially because 50% of these patients, I mean, experience like an incomplete recovery of that central vision. Of course, it's more common in patients that are like affected in the fovea, and this patient was very close to affecting the fovea. And 20% of these patients ended up with a 20/40, so we were lucky. And well, I already mentioned that the residual was very high. And so this is the case that I brought to you, and this is just a resume, like, or a review in images. I hope you like it. And just a little photo of our end of year activity last month. Really, where we were, my mom and a colleague of hers, they are psychologists, and they came to do work with us, so we could like look inside of us and be ready for this year. So I'll leave you with this quote that is not terrible to suffer, not to die, but to die in vain, of Sartre. And I think we're ready to like make the meaning of our lives, continue working in HDLF. So thank you.
Thank you, Isa. It's a great case. I think I saw one when I was a resident, but I've never seen such great pictures. It's amazing. Really great case. Thank you very much for sharing.
Thank you. It's been, I mean, I'm seeing this patient at the end of this month because I started seeing the patient in my fellow, and then I kind of stopped, but then she kind of found me again. So now we're continuing there. So I'm just very happy she felt comfortable coming.
Now, I just have a question. You
Yes,
mentioned
please.
there were some lesions on the right eye as well. Correct? And you studied them. You did an FA.
Yes.
Is that something you're going to keep following? Is that something you're going to, could that progress to loss of vision? What do you think about that?
In the right eye?
Yeah.
Oh, well, I can show you again. I didn't saw that clinically in the right eye, but it calls my attention when I kind of saw the images. So I'm thinking, because I saw the superior temporal in the left eye, but not in the right eye. So that's something I catch with the photo. And then I will say, as you see the FA, it looks very clean. So I will think that maybe it's an artifact.
Oh, okay.
But of course, I'm following both eyes.
Yeah.
Thank you.
Okay. Yeah.
I don't know if anyone else wants to ask questions or comment or wants to share an experience, because I'm pretty sure like USA look more patients of MP than we do.
Isa, I have a question.
Hi.
Hi, thank you for that. Was such a great presentation and so interesting. I was wondering if it's, in this case, she presented with very, very good vision. Is that typical of AMPI, or was that unusual that the very central vision was not as involved?
It's very common. It's very common. It says that the literature said that 50% recovered a full vision and only 20% has like a 20/40 or worse. And then, but usually if I recall correctly, I think it was less than 60% that affect the fovea.
Okay.
So this is like the best prognosis. So if you're gonna have a white dot syndrome, it better be this one. Not that I'm wishing on anyone, of course.
It was the initial comment you made about the steroids. Now knowing that there's inflammation from the choroid, I guess it makes sense that you would go back and do it again, correct?
Say that again?
I mean, knowing that what you read, that there is
Mhm.
inflammation coming from the choroid,
Mm,
and that you gave her steroids initially orally, and then you said, you know, you didn't know about if that was correct, but I heard you say you would do it again.
yes. I mean, you're right, because I mean there's inflammation. There hasn't been described any autoimmune how do you call ay, ¿cómo se llama?
Disease?
No, of course,
Or
there
process?
we still don't have an etiology, clear etiology, but also like when they study these deposits that
Yeah.
you can find in the vessels, they haven't really found any. So at the end, we're still having, like, we know it's a choroiditis and it's coming from the choroids, and the inflammation could be just local, but also there are some patients that have been described with central nervous
Signs.
vasculitis. So that's why I did an MRI with this patient. So that will need definitely systemic. So most of the authors will treat these patients that have affected like the brain vessels, but I think Jesse will argue with us that he wouldn't treat just because it make us feel a little bit better or more comfortable, or maybe like because the patient will just be happy that we give him something. And because there's no evidence, there's no like enough evidence that we should be treating them with or urged to treat with steroids. But like that's why I said I'll probably do it, but maybe Jesse will say I shouldn't.
Well, sometimes you go with your gut and
Yes, I know. I mean, as a
I
young,
think it
I
went
would,
well.
yeah, as a young professional, we're always trying. We want to fix. We want to do. But I think this is something that we should be learning from Gas, from Januzzi, from Jesse, and I mean we should observe first. And there's a probability, a very high probability that this patient went just same resolution without treatment.
Mhm. Thanks.
Thank you.
All right, guys.
Thank you very much.
Congrats, Lisa.